Okay. So I think this pandemic of metabolic syndrome and NAFLD is overtaking the world now in all areas. And of course, we have this pandemic of conferences also because of this. These three pandemics are actually poorly managed. In fact, I recently read very interesting statistics that I believe for the first time in the history of mankind, the lifespan of the present generation is going to be less than the previous generations. And this is because of this metabolic syndrome. So unless we conquer this, there are going to be problems. Now what I'm going to do is I'm going to give a very simplistic endoscopic view. I know that as hepatologists, you look into various other things, but I'll try and simplify things because we endoscopists like to simplify things. I'll start with the fact that most of the metabolic syndromes because of insulin resistance. Now, there's a big debate about this. Some may argue it may not be because there is evidence that actually intrahepatic fat starts insulin resistance, not the other way around. But anyway, as I said, I'll keep that argument aside and go to a very simple thing. That insulin resistance is responsible for the obesity, and insulin resistant factor that's being identified now is responsible for the NAFLD. So obesity and insulin resistance are the two common factors responsible for NAFLD, and we have two forms of endoscopic therapy to deal with it. One is the restrictive therapy for obesity, the metabolic therapy for insulin resistance. So this is how we'd like to simply look at it. If you look at, this is a little complicated cartoon, but shows that there are two areas, that is for restrictive, to produce restrictive techniques, we have several endoscopic techniques like this, the gastric, majority of them to restrict the gastric volume. For metabolic, we have actions on the small bowel. So let's start with the gastric restrictive procedures. All the time when, as endoscopists, we are doing these procedures, we are concentrating on obesity, how to reduce weight and so on. We didn't put much emphasis on what happens to the liver till about 10 years back when people started looking at the liver enzymes, the liver histology and so on after doing many of these restrictive procedures. The first study came from Singapore. A group actually randomized group of patients into those who had a balloon, intragastric balloon put in, and those who did not have intragastric balloon put in. In fact, this study was unique because they did a paired liver biopsies before and after, 6 months after the procedure, to see what happens when a balloon is put in. And this showed very clearly that in patients who had a balloon put in, all their steatosis, other parameters got better, but the fibrosis didn't get reversed. In fact, even the inflammation was similar. So the only thing that happened in patients who had intragastric balloon for 6 months was a decrease in their hepatic steatosis. So this was disappointing. There have been several studies in between, but just 10 years later, probably one of the best studies in this area has been published in Clinical Gastroenterology Hepatology by Barham and his group from Mayo, where they took 21 patients. This was an open label study where they followed 21 patients who had a balloon placed and followed them very carefully with again paired biopsies before and after. And you can see from this slide what they found was there's decrease in steatosis, there was decrease in other parameters, but most interestingly, they found that there's a decrease in fibrosis in 50% of the patients. This was interesting because you can see again from this charts that all the parameters decreased. Fibrosis not as much as others. For example, 70 to 80% of the patients, if they lose weight, their steatosis goes off. But the fibrosis was actually decreased in 50% of the patients. A very important observation, part of the study was that there's no correlation between weight loss versus the improvements in liver histology. We all used to think that you lose 5%, you lose fat, you lose 10%, you reverse fibrosis. This didn't happen. So obviously this theory of weight loss versus amount of changes in the liver histology was not true, indicating again that there's some other factors in addition to weight loss which may be playing a role in what happens in the liver in these patients. I'll come a little later into this very interesting study that came in this. So this was a sort of a meta-analysis which looked at all the balloon therapies in patients, and you can see there are several of them. Most of them used the balloons that we use currently in practice, the BAB or the Orbera balloon. They were both prospective studies, many of them not randomized, some randomized, all of them showing that there's a decrease in their BMI and also showing that there's an improvement in the liver function test. Now, what in fact these studies suggested is that these decreases or changes in the liver histology probably was temporarily. And there's a suggestion at this point of stage, again, very interesting suggestion by Burham and his group, that you put a balloon, you control the steatosis, some patients you actually decrease the fibrosis, and then put him on GLP-1 analog drugs. And maybe then you can continue. There's a study, which is an interesting study is going on with this thought that you put a balloon, improve the liver histology, and then put them on GLP-1, and then you find that on long term these patients are doing well. Initial results from this study suggest that this could be a good strategy in these patients to control NAFLD. Now, balloon is a temporary thing. What about more permanent methods of restriction? Endoscopic sleeve gastroplasty is, of course, the technique that's being practiced everywhere. I think a lot of people are doing it now, even in our country. And again, this was the first study in 2020, which looked at what happens to the NAFLD in the patients in whom ESG has been done. This was a little disappointing study. You can see that only 20% of the patients, their hepatic fibrosis improved. In the rest of the patients, the other parameters, steatosis came down, inflammation came down, but the fibrosis didn't change. And again, there's no correlation between the weight and liver histology in these cases. Now, we know that there's a huge geographical variation between different countries in terms of liver histologies and what happens in NAFLD. We have the so-called lean NAFLD in our country and so on. So what we did in our institute was to try and look at what happens to these patients with NAFLD who underwent ESG. We have a group of endoscopists in our institute very actively doing ESG. And you can see this is a study we published some time back where we looked at all the parameters, ALT, hepatic steatosis index, the NAFLD fibrotic scoring, and so on. And you can see again, all the parameters improved not only at 6 months but 12 months. These patients are in a follow-up now. Now we have about 2 years follow-up. They continue to do well, indicating, of course, we didn't do biopsies in these patients. It's very difficult to convince patients to get biopsies done. But our study now clearly shows that in general, if you look at these patients, both in terms of inflammation versus other histological parameters, there seems to be an improvement with ESG. So I think this is something that we should actively look at. And again, I want to emphasize that there's no correlation between the amount of weight loss and the improvement in liver histology in these patients. And this is again showing very clearly how pre and post EHGs, there have been improvement, especially liver function tests quite dramatically improve. The AST to ALTs come down. Again, there were studies which looked at it worldwide to see what are the differences, and there have been several problems. One of the problems with endoscopy or endoscopic studies is they're not as rigidly controlled as hepatologists want them to be. So therefore, there's a lot of criticism which comes up in editorials on these studies and so on. This is one of the problems, but we have to do with what we have. This is actually another very interesting study, is still in press, a group of, again, a multi-center study from Europe and US, which is looking at using POST technique. POST technique is one which also is for restricting the gastric volume endoscopically, but not as much as with ESG. And in this study, again, they're finding that there's fairly long-term now, 2 years, that there's improvement in all the parameters biochemically, and again, they did paired histology is showing improvement. So if you look at all the studies that are published regarding restriction using a sleeve gastroplasty in patients with NAFLD, there seems to be now a fairly good consensus that histology improved by indirect methods. We have very few actual biopsy studies, but definitely if you look at the liver enzymes, the changes are fairly dramatic, indicating that there is significant improvement in these patients. Now, this is regarding the part about restrictive therapies. Now, what about the metabolic therapies? And metabolic therapy is very interesting because the whole concept about metabolism, what controls metabolism, has changed in recent years. A lot of this work actually is by a group called from David Cummings and others working in this area. And of course, we all used to think that pancreas was central to our metabolism, especially the glucose metabolism. We know this is wrong. We know that the metabolic control is totally in the duodenum, the second, third, and fourth part of the duodenum, where all the control lies. There is significant evidence for this, and for example, when we are eating, and this is again just to show you that there are many controls when we take food normally, and the first time the food comes into contact with an endocrine system is in the duodenum, the enteroendocrine system in the duodenum. And when this happens, what happens is the duodenal secretions, the cells in the duodenum, the endocrine cells secrete two types of substances, the incretins and the anti-incretins. They label incretins, there are specific names now for the many of these. For the anti-incretins, especially now, we have changed it to, because there's factors which are being identified, the insulin resistance factor and the diabetic intestinal peptide. These are the names which actually are being isolated now. Now, what happens is, this two balance together producing an euglycemia, and this is what the metabolic control is about. But what happens is, when we take refined foods, this is what is happening now, when we take all these refined foods, the insulin resistant factor increases. Now, why does this happen? This happens because body doesn't want you to develop sudden hypoglycemia. You take a very refined food, your glucose level shoots up, and because insulin level shoots up, you develop dangerous hypoglycemia. To prevent that, the body has developed a mechanism where the anti-incretins, or so-called insulin resistant factor, comes into play. But unfortunately, in the westernized society, diet and all, we keep on taking this refined food, so the levels of the insulin resistance factor is going up. The whole histology of the second part of the duodenum has changed to favor more secretion of the insulin resistance factor. You develop insulin resistance, and subsequently you develop, of course, everything else associated with this insulin resistance, the metabolic syndrome. And we know, of course, there are several things, not only diabetes, NASH, and so on, but other things associated with this. In the last few years, there's been a large amount of study in this nutrient cell interaction in the duodenum. And I'd recommend, for at least for the younger colleagues here, to read two very good reviews, one in Cell Metabolism, the other which has come in American Journal of Physiology, which has got extremely large volume of studies done, which has clearly looked at what happens when the duodenal cell at the enterocyte comes into contact with a nutrient, lipids, proteins, and so on. And this is where the identification of the duodenal intestinal peptide, or so-called insulin resistance factor, is being identified. So this is some very good data, and this actually plays into the fact that when people are losing weight because of gastric restriction, it's not just the weight itself that's being lost, which is related to liver histology, but also some other factors like insulin resistance factor, which seem to play a role. So our correlation between weight and histology may not be very accurate because of this. We have a lot of evidence for this, both human and rat studies. Human studies are, if you take biopsies from the second part of the duodenum in diabetics, type 2 diabetics, you'll find a huge volume of enteroendocrine cells, the so-called neuroendocrine cells, we used to call them. The large volume is large, and in rats which have been fed Western chow, again, if you look at the histology, you can actually demonstrate increasingly large number of these cells. So this is one evidence. The other evidence, unfortunately, we had for very long, and we didn't look at it critically as physicians, was when surgeons do bariatric surgery, especially Roux-en-Y bypass, these patients lose weight after 1 month, 2 months. But what happens is they lose dramatically. They have a decrease in their blood sugars in the 4th post-operative day, 2nd, 3rd, 4th. In fact, I've seen some of them in our own institute going to severe hypoglycemia. The glucose levels goes down to 30, 40 without anything, just bypassing the duodenum. So this is a strong evidence that we didn't actually correlate with what is happening in this factor. And one of the most elegant clinical experiment in this area has been done by David Cummings' group, published in Annals of Surgery. And you can see this very interesting. So what they took is, they took their patients who had undergoing Roux-en-Y gastric bypass surgery, who were diabetics. And after the Roux-en-Y bypass surgery, you see the food is bypassing the duodenum, going directly into small intestine. They started giving them oral feeds, and within 2 weeks, they became normoglycemic, without any insulin, without anything else. Now, they took permission from the ethical committee and put in gastrostomy tubes in the stomach. I don't know how they allowed ethical committee, but they allowed a PEG tube to be put in. They put in PEG tube, and then they started feeding both orally and through the PEG tube. Then immediately they became hyperglycemic. And when they removed this PEG tube and started normal oral feeding, they became normoglycemic. Now, this is one of the strongest evidence we have that duodenal nutrient passage strongly influences insulin sensitivity independent of weight change. So this is where we're coming to now. There are other factors rather than weight, which is controlling what happens to the liver in terms of steatosis, inflammation, and so on. So this was a very elegant study. So based on this, there were some other things to see what endoscopists can do. In fact, several years back, a group of South American, very adventurous endoscopists started using this duodenal-jejunal bypass sleeve, the endo barrier. Actually, they started using it for obesity, and they found that obesity, when they used it, the weight loss was not much, about 5% and things like that. But what happened in these patients was a fairly dramatic control in diabetes. And this was a large study which was subsequently done, published recently, where they showed when you use this duodenal-jejunal bypass liner, which means food comes into the duodenum, bypasses the whole duodenum and goes into the jejunum. They found, you can see, all the parameters improve. And of course, the most important is when ALT levels are high, they are much decreased much more. So this is what was the finding then. So based on this, can we do something more permanently? And this is where the DMR, duodenal mucosal resurfacing, came. This was a concept which came from a cardiologist actually, where they started using hydrothermal therapy to burn the duodenal mucosa after raising the submucosa so that it's safe. And then you find response to see what happens. This is the actual technique. Again, I won't go too much in details. I had an opportunity to do this at the Brussels Erasmus Institute. Very simple technique. Anybody doing upper GI endoscopy can do this technique. It's fairly simple. You just mark out the second part of the duodenum to the fourth part and put in this balloon, and you burn the complete mucosa at 80 degrees. The initial picture of the duodenal mucosa looks very, very lot of hyperemia, ulcerations, but very quickly it heals. But what's the difference? Difference is if you take histology biopsies from this mucosa, they don't contain the previous enteroendocrine cells, and that's the difference. And the first study published in Gut in 2019, called the Revita 1 study, clearly showed that these patients, not only the type 2 diabetes for which it was done improved, but you can see the ALT levels, AST levels improved, and of course, HOMA-IR indicating that insulin sensitivity increased in these patients. The subsequent study was a randomized control study done in Europe, in South America, and so on. Again, very clearly showing that we look at what happens in terms of their elastographies, MRI elastographies, there's a dramatic decrease in the hepatic fat. Again, in some of the patients that had biopsies done, we showed a difference in terms of histology, in terms of inflammation, and so on. So what this does is, this duodenal mucosal resurfacing seems to influence all the metabolic parameters. There's not only reduction in A1Cs, AST, ALT, FIB4, and so on, but also in antioxidant levels, anti-inflammatory levels. So this is a very interesting concept. We now have, because of the large amount of knowledge we gain from what is happening in the labs in terms of the physiology of the duodenum versus the clinical knowledge that's coming with this. There's a lot of data which is coming in, suggesting that we seem to be able to control the metabolic process in the duodenum using these techniques. In fact, there's one study in Erasmus which Dr. Jack JB and the group are looking at NASH patients. They didn't find such a dramatic decrease in fibrosis, but this is a study which is ongoing. In fact, we are doing a study with them now. We're looking at these NASH patients to see if there's some reversal in fibrosis when you use any of these techniques. Of course, burning the mucosa is a very primitive way of doing. Hydrotherapy is a very primitive way of doing. This is what they started with. Now we are getting better techniques, and one of the techniques that's now being advocated is electroporation. The same technique that the oncologists use. We can, through the endoscope, we can actually produce pores in the duodenal mucosa and completely destroy the duodenal mucosa. We have a study with IIT Kanpur now in our institute where we're using the electroporation technique in the animal lab, and hopefully, if it's useful, it can come very quickly into thing. And you see what happens, 24 hours, the whole mucosa is completely gone, very safe, and in 3 weeks, the new mucosa comes, but the new mucosa does not contain the enteroendocrine cells. And provided these patients don't go back to the refined diet, we can maintain the mucosa that way with a low level of the cells. There are a lot of new other therapies coming in. In fact, the Israeli company has come up with a laser which can be used through the endoscope to very quickly burn the mucosa. Radiofrequency ablation, what we use, for example, for Barrett's, can also be done for this. So all these new technologies are coming in very rapidly. And my feeling is that, that we have the basic data now. Within the next 2 or 3 years, we're going to get all these technologies to help us use this. And again, you see, there is some evidence that the metabolic process can be altered both by the endobarrier and by the DMR techniques that are available now, and fairly significant group of patients. We now have over 2,000 patients in whom DMR has been done, and showing that very low complication rates, stenosis in some patients, but otherwise complications rates are very low. So I think, again, giving you the simplistic endoscopic view of how we look at it. If we look at endoscopic therapy for NAFLD or NASH, those who are obese, we would suggest endoscopic balloon or gastroplasty. If we're using in balloon, you would like to continue with GLP-1 analogs on long-term basis. But if you're doing only gastroplasty, then maybe you can in fact combine it with DMR. There's a new concept, and this is a very interesting animal study which has been shown by Barham and his group in Mayo, where they combine ESG with DMR, and the control of NAFLD is quite dramatic in these animals at least. So again, the very early human studies are being done in Australia in this. Of course, for so-called lean NASH that we see, only plain endoscopic DMR may be sufficient. So I think, again, as I said, I got a very jaundiced tunnel view of this, that endoscopy may be something that's useful, but I think ultimately it's going to be a combination of endoscopy with the newer drugs that are available, and to a large extent, this pandemic can be controlled, and hopefully we'll have less of these conferences in future then. Thank you.